GnRH analogs and antagonists used in eye cycles. Introduction to GnRH analogs and antagonists. Gonadotropin-releasing hormone, GnRH, is a key regulator of reproductive hormone release. GnRH analogs, agonists, and antagonists are used in assisted reproductive technology, RT cycles, to control ovarian stimulation and prevent premature ovulation. Primary goals: suppress premature LH surge, enhance follicular recruitment and synchronization, optimize oocyte retrieval and fertilization rates. 1. Types of GnRH medications used in RT. Category: examples, mechanism, usage. GnRH agonists: leuprolide, Lupron, buserelin, nafarelin. Initially stimulates, then suppresses LH-FSH secretion. Long and short protocols in ART. GnRH antagonists: cetrorelix, cetrotide, ganirelix, orgalutran. Directly blocks GnRH receptors, suppressing LH surge. Flexible short-term use in ART cycles. 2. GnRH agonists in ART. Mechanism of action: initially stimulates FSH and LH release, flare effect. Prolonged use leads to pituitary desensitization, downregulation, preventing premature ovulation. Protocols using GnRH agonists. Long protocol. GnRH agonist started in luteal phase, day 21 of previous cycle. Continued until ovarian suppression, then gonadotropins are added. Used in high responders, but higher risk of OHSS. Short protocol, flare protocol. GnRH agonist started in follicular phase, day 2 to 3. Used in poor responders to enhance FSH release. Advantages: complete suppression of LH surge, better follicular synchronization. Disadvantages: initial flare effect may cause hormonal fluctuations. Requires longer duration of treatment. 3. GnRH antagonists in ART. Mechanism of action: directly inhibits GnRH receptors, leading to immediate suppression of LH surge. Protocols using GnRH antagonists. Flexible protocol: started on day 5 to 6 of ovarian stimulation when follicles reach 12 to 14 millimeters. Prevents premature ovulation while allowing continued follicular growth. Fixed protocol: started on day 6 of stimulation cycle, regardless of follicle size. Advantages: immediate suppression of LH, no flare effect. Shorter treatment duration, lower risk of OHSS. Disadvantages: requires precise timing of administration. Slightly higher risk of premature LH surge in some cases. 4. Comparing GnRH agonists versus antagonists in ART. Feature: GnRH agonists, GnRH antagonists. Onset of action: gradual, 3 to 4 weeks. Immediate. Suppression mechanism: downregulation of GnRH receptors, direct receptor blockade. Risk of OHSS higher, lower duration of use, longer, shorter, preferred use case. High responders needing complete suppression. Patients at risk of OHSS flexible cycles. 5. Role of GnRH analogs in triggering ovulation. GnRH agonist trigger for final oocyte maturation. Used in GnRH antagonist cycles to trigger ovulation. Benefits: lower risk of OHSS compared to HCG trigger. Better luteal phase control. Example: leuprolide 0.5 to 1 milligram subcutaneously. HCG versus GnRH agonist trigger. Trigger type: HCG. GnRH agonist. O. HSS risk: high, low. Corpus luteum support: strong, weak, requires luteal support. Effectiveness in oocyte maturation: high. 6. Risks and considerations in GnRH use. Side effects: hot flashes, mood swings, headaches, especially with GnRH agonists. Injection site reactions, GnRH antagonists. Precautions: luteal phase support required in GnRH agonist trigger cycles. Not suitable for all patients. Protocol selection is key. Conclusion: GnRH analogs and antagonists in ART cycles. GnRH agonists and antagonists are essential in ART to regulate ovarian stimulation. Agonists prevent premature ovulation by down regulation, while antagonists offer immediate LH suppression. Choosing the right protocol minimizes risks like OHSS and enhances RT success rates.